Okay. First of all, it's great to be here. Thank you very much. It's an amazing assembly. Thank you, Roman, for putting this together, the Dilwalk Foundation. This has been a really interesting conference the last couple of days to take in a lot of information from a wide sort of scope. There's people who are looking at the clinic, and people who are looking at new technologies, how they all integrate. So I kind of was taking a bit of a step back, a little bit of a meta view, and talk about sort of rewiring the way we talk to people about the very things we're doing in here. So one of the questions that Roman had asked me earlier on was like, what about the impact? Like, what kind of impact can this conference have and groups of people? And of course, there'll be impact between us, but what about the impact between us and the general public? So I kind of wanted to walk through this a little bit. We typically think of science sort of publication generally. We're doing research in the lab, in the clinic, we publish peer-reviewed work, we disseminate it, we get very happy when we get published in a high-impact journal, we go to conferences, and we think that trickles out somewhere in the education system. People begin to believe our p-values, and then we have people behaving differently as a result of statistical significance, and suddenly people are healthier and better. And that's kind of not the case, right? So during COVID, the WHO made a statement that we're not just in a pandemic, but we're in an infodemic. And they're saying that this might be just as dangerous as the actual pandemic. And this is a concern that they raised in 2020. And it reminded me of the late, great Carl Sagan, who said that we live in a society exquisitely dependent on science and technology in which hardly anyone understands anything about science and technology. And he was famous for being a public communicator of science. And he was concerned about this. I recommend his book, The Demon Haunted World. It's fantastic. So I kind of wanted to, for the next 45 minutes, no, I'm just kidding. But I wanted to very quickly run through a bit of the history of how things have changed, how mediums have changed, and how that's affected science for the better and for the worse. So of course, the printing press, Gutenberg comes out with it in the mid-1400s. Phenomenal technology. We can now reproduce books. And you can actually see an inflection point, right, when it gets introduced. You can see that the number of university courses that are science, that are taught in universities, goes up dramatically. And this is great, right? So from the first 100 years, 20 million books. Over the next 200 years, 150 to 200 million books get produced. 1665, we get two of our first journals, the Philosophical Transactions of Royal Society and Journal des Savants. And these are great journals. This actually creates a sort of method that we're used to now today. This sort of submission, peer review, we get people to kind of do sort of like the due diligence, and we publish it and we disseminate. By 1800s, we had over 1,000 scientific journals, and we also had a rise in literacy rates. This is phenomenal for the public understanding of this revolution that's happening. Science gets institutionalized and professionalized. For example, we actually get the word scientist emerging. People weren't called scientists before then. They were called natural philosophers. But there's limited public access, still slow, still hierarchical. Fast forward to 1895, we get the radio. And the radio, we get a huge uptick. From 1925 through 1945, 20 years, especially during the Second World War, everyone pretty much starts listening to the radio. And this plays a really important role in science. In fact, it's the first time science is broadcast at a population scale in real time. So people are making, not just Winston Churchill talking about the Second World War, but we're also talking about public health issues. For example, the BBC gets founded in 1922, CBS, NBC, 1926, 1925, 1926. And we also had tuberculosis awareness campaigns. So people are now getting public health about, what is it, the infection, and raising awareness around this thing that people can't see and so on. It's played a very important role in curbing tuberculosis. Hygiene, sanitation messaging, rationing during wartime. This is all mediated through the radio. And for the first time now, we started getting a new kind of person emerging in our media ecosystem. This is the interpreter. This is somebody taking that scientific knowledge and making it relatable to the general public who do not have that scientific background. Fast forward, television. Television in the 1950s and 1960s was remarkable. In 1950, less than 10% of Americans owned a television set. And a decade later, over 90% owned it. It's the fastest adoption of a mass technology by a population. And this changed everything. There's a famous Canadian named Marshall McLuhan from the University of Toronto. And he's famous for talking about the medium is the message. And what he was pointing out was that the very medium through which we provide content to the public shapes the content itself, that the medium is superordinate to the content. And this is really important. For example, when Richard Nixon debated JFK, famously, when people watched them on TV, and you asked people who only listened to the debate on the radio, people who listened to the radio on the radio thought that Nixon had won the debate. When people watched it on TV, they thought that JFK had won the debate. And what's the difference? Well, of course, JFK is better looking, he's good for the TV, and of course, that's appealing. And that changes the way you process information and you think about it. So, Cosmos, Carl Sagan I mentioned earlier, 500 million people around the world watched this show. And it inspired a whole generation of people to think about physics, our place in the universe, and so on. And here's the thing about television. There's no literacy requirement. You don't need to know how to read and write. You just get to watch and enjoy. This is a very powerful platform. But something changes here now. Trust is no longer about that peer review process. Trust is about the person now who's standing in front of you talking to you. Do you like this person? So it becomes more person-mediated. And this is sort of the advent of the first, what you might call the influencer. If you think of Carl Sagan as one of the early influencers. Fast forward to smartphones. Steve Jobs announced his smartphone, the iPhone in particular, in 2007. And from 2008 to 2020, you pretty much have everyone owning a smartphone now. And by 2013, actually, in 5 years, over 50% of Americans owned a modern smartphone. Very rapid uptake. Check it out. This is what's relevant to healthcare and what I think everyone here has to deal with. 70% of adults search health information online. More than half of them search for it on their smartphones. They're pulling out their phones right now asking ChatGPT, I've got a cough. What do you think it is? Can you hear my cough? I got a headache and a cough. Does that mean something? So questions like that. It has real-world implications. In 2020, this is the trust in scientists, 87% of people, when they're polled, trusted scientists. By 2021, that dropped to 73%. And I'm very sad to report that dropped even further. By 2024, it's 65%. The trend is not looking good. Physicians, not much better. 2020, 74%. By 2021, 56%. By 2024, only half the population trust their doctors in their hospitals. I mean, if this trend continues and we're in 2026, 2028, 2030, who are they trusting exactly in this new environment? Some behavioral changes. It looks like the numbers didn't pop up. That's okay. I'll try to remember what the numbers were. But I believe the number was about 35% of people are acting on health information with online information without consulting a physician. So they're just looking it up online. They're saying, that's probably what I have to do. I'll skip the doctor. About 25% report experiencing harm or know somebody who experienced harm from coming across misinformation online. You have almost 50% of people who are avoiding or delaying treatments that are recommended because, again, of the information that they're receiving online. This is a very different relationship now. Things have been inverted. Before, it used to be that you would have a centralized way of talking to people. And so, if you're a non-expert, you say, well, I just don't know, I got to find the expert. Now the experts have to seek the people out. So 50% of people say there's an increase in anxiety or mental distress linked to all this health information exposure. This is a mental health issue. People are getting anxious, they're worried, they're concerned. This is most likely only going to get worse. But this is not the first time we've had to deal with issues like this. We have doctors recommending cigarettes, apparently, between the 1930s and 1950s. Right? It's strange. I mean, Dr. Ferrer's not here right now, but I'm pretty sure he would feel quite cringed by that. But the data existed at the time that there's a link between smoking and lung cancer. And even though that data existed, we still had posters like this and campaigns like this. So it's not enough to have the data. It's not enough to have it published. It's important to communicate it and communicate it effectively. Another one is AIDS denialism. Now, there are people who for the longest time, even to this day, deny that HIV causes AIDS or AIDS is even a real condition. In South Africa in specific, this became policy. Discourse changed into policy. About 300,000 people died because they could not receive antiretroviral therapy, and tens of thousands of people were infected because, again, the dialogue around the science was corrupt. So there's a price we pay too. We talk a lot about here about lowering healthcare costs. Things are really expensive. We want to get our companies funded. AI is super expensive. How much does it cost to build the data center, so on and so forth. Well, it costs money for people not to be literate about health. This is a study that's famously cited over and over and over again from 2007. And they say about $100 billion a year, just in the United States alone, cost attributed to people not knowing enough about health, just health illiteracy. And this is back in 2007, so if you did cost adjusted, it's probably over $300 billion now. And this is only probably getting worse, considering today's environment is noisier. So, you can't be here in Alberta and not talk about Wayne Gretzky. So I love his quote, "I skate to where the puck is going, not where it has been." So let's think about where we are right now and where things are going to be in 2027, 2028, and so on. There are 5 billion users of social media. Almost 65% of humanity right now is on social media. And almost all of them are using devices in their hands to access it. And if you look at large language models, we talk a lot about AI, and we talk about very specific uses here. Agentic AI and things of that nature, that's fantastic. That's awesome. But the casual public user is also using it too, and they're using ChatGPT and so on and so forth. But 1.5 billion. This is decentralized, unregulated, unmoderated. Just think about what kind of conversations they're having with these large language models and what kind of conversations they're avoiding and bypassing. So, I want to show some examples. Dr. Blacksall, I believe, brought up the fact that there's only 1 hour of education received by physicians or OBGYNs around menopause. That's a real issue. Well, Dr. Louise Newson, who is a Brit, she has a podcast. She's on Instagram. She's on YouTube. She has over 8 million downloads, and she's known as the medic who kickstarted the menopause revolution. So how does she do it? She didn't, one by one, patients coming to the clinic. She didn't knock on doors. She went where people are. They're online. They're using social media. They're looking at large language models. And she's changed the conversation and dialogue around women's health. This is how change happens today in today's media ecosystem. There's a number of other, I wanted to throw up a slide here. Here's Alan Alda, a famous actor known from MASH and such. He's got this Center for Communicating Science at the Stony Brook University, quite famous for doing that. He says communication isn't something you add onto science, it is the essence of science. And there's a number, I just threw this up on a slide. There's McGill, they have this Office for Science and Society, separating sense from nonsense. There's a Science Up First, with connections with the University of Alberta here. It's a national initiative trying to collaborate between scientists and so on, professionals. So I guess maybe what does this talk about a little bit? We're talking about precision health, we're talking about longevity. Longevity is a long conversation, right? It's not like a quick intervention. So imagine a 20-year-old today that you want him or her to be thinking about what there might be at 80. That's a 60-year conversation you're going to be having with this person. That's longevity. You have to have this long, sustained relationship with these individuals. My dad used to always say that the cornerstone of a good relationship is 3 things: communication, 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 right? So what is the takeaway, I guess? Well, I want to point out that health communication is a prophylactic. It is part of treatment. It is part of that clinical responsibility. It's also the responsibility of researchers who do work in your labs. So here's a few takeaway points. You got to build trust before the crisis hits. You have to train scientists to communicate repeatedly, not occasionally. It's not just good enough to do a poster presentation or oral presentation or learn how to write a paper to be published in Nature. It's also important to know how do you dialogue with your neighbor, because your public is your next door neighbor. It's your grandmother, it's your aunt, it's your friend, it's your friend's friend, it's your school teachers. It's just regular folks. And you have to be able to talk to them on their level and make them appreciate the work that you're all doing. So this is for everyone, not just for peers. And now we also have to enter these algorithmic spaces. Right? You have to be in those spaces. You have no choice. I mean, it's like the other individual, Wish, had said earlier, his spirit animal is the bison. I think that's great. Go into the storm. We're not going to be able to avoid this. This is coming. This is here. So it's best to figure out a way. And you're not alone. And we're not alone. Clearly, look, this is a group here. We're together. You could do it collectively. You collaborate. You partner. And realize you have real-world impact by communicating to the public. And then treat public understanding as a measurable health outcome. And down to 5 seconds, which is perfect. And the last sentence is, a discovery that cannot survive the information environment will not reliably become public health. So I applaud the work that's being done here. I'm inspired by each and every one of you that are here. Every conversation that I've had is phenomenal. But I would also love that inspiration to also be extended to the general public. And maybe we can work together to figure out how to do that. So thank you very much. Great. So the next session is called the Innovator Session. It's going to be kind of nice. A little one-on-one with three very, very fascinating people. So the first person I want to introduce is Dr. Rafaela and Andrade. And she did her PhD in biochemistry and molecular biology at the University of, say again? Oh, Dalhousie University. That's it. Thank you. And her focus was on muscle metabolism and muscle-related diseases. And she took that very seriously and founded a company called Myomar, where she's focused on muscle, longevity, and very interesting take on how we might be able to measure that in ways that are much more scalable than we usually expect to measure muscle weakness and such. So I'd like to introduce her to on stage and have a conversation with her. Please welcome her. Awesome. Thank you. So right off the bat, why muscles? What's so important about muscles?
Yeah, that's a great comment and question. So for most people, muscle is just another organ, but really what most people don't know is that muscle is actually our longevity organ. If we don't take care of our muscle, we can impact our brain health, we can impact our bone health, liver, kidney. So all the other organ functions is actually very dependable on muscle. And today, if you walk into your medical doctor and request for a muscle test, there isn't a muscle test that he can order for you. Maximum they will do is analyze your muscle mass through a bioimpedance machine or maybe a DEXA scan, but that's not nearly close to understanding your muscle health. So we really were lacking the ability to understand muscle at the molecular level and try to improve to be more personalized for people to have a healthier, life quality and live longer and better. Yeah.
Well, let me take me back to the beginning. So is this something that you sort of were discovering in your graduate school work and you realized, hey, look, there's a way for me to measure muscle weakness and muscle metabolism? Do you mind?
Yes, absolutely. So when I was doing my postdoc, we had an animal model with a muscle atrophy. So we knew that animal model was going to develop muscle atrophy eventually. And we tried to understand what was the difference between that animal to the wild type. And we decided to measure a couple biomarkers in their metabolism. And we saw that there was an imbalance of biomarkers in the model that had muscle atrophy compared to the one that didn't. And we put these animals into an exercise routine to get them to recover from muscle atrophy. So they didn't recover 100%, but they recovered quite a bit compared to the wild type. And what we saw was that those biomarkers that were unbalanced when they had a high level of muscle atrophy start to return to normal levels. So then that sparked the idea, this is the metabolism that we should be looking at. And maybe we can find these biomarkers in humans and prevent muscle atrophy before it actually becomes a problem. So then we design an entire clinical study. We're proposing to the healthcare system to work with us to show that the solution actually works for humans. And we showed that through a clinical study.
And what is that solution then? What was the platform that you developed?
Yeah, so the idea was to have accessible tests. So we had the opportunity to work with serum, but I said, most of the tests are serum. It's not very nice to take blood all the time. Let's try urine. So then we decided to look for those biomarkers in urine, and we were successfully at finding them in urine, and we were able to validate in urine. So now we have a very simple test that analyzes urine biomarkers for prediction of muscle health, and gives individuals specific information of what's wrong with their metabolism before muscle loss becomes a problem.
So what are these biomarkers that you started off with?
Yeah, so we look into three areas of muscle metabolism that are really important for aging. The first one is the ability to produce enough proteins to grow, calcium handling, which is very important for muscle contraction. Then we look into ATP levels or levels of energy for muscle function. And if you have unbalance in the metabolism, actually is linked to mitochondrial dysfunction, which is very important for aging as well. Then we look into reactive oxygen species. When reactive oxygen species rise in the body, it destroys muscle fibers, and metabolism of muscle is really dependent on a good balance of oxidative stress. And if you have a catabolism and anabolism disbalance, then you're going to lose muscle quite fast.
So the mitochondria is near and dear to my heart because part of my grad school work as well. And that's also becoming a lot more prevalent in conversations and dialogue. So once I have, let's say, biomarkers, first of all, at what age, before we get into mitochondria, at what age should you start being concerned about your muscle? Like, how would you look at a 20-year-old, say, versus a 40 versus 60 versus 80-year-old?
Yeah, I think the youngest we have looked was the athlete at 16. And the oldest, probably somewhere at 93, I think, was the eldest. So you can see that it's a very large number of people in different ages, but really we start losing most of our muscles around 30 years old, which most people don't realize that. And if you don't take care of at that stage, then later in life can start becoming a huge problem. And women in menopause, for example, women between age 45 to 55 years old, you're going to lose a lot of muscle because of hormone dysregulation. But what you don't realize is that losing muscle at a young age, especially women, can affect your brain cognitive function. And the research has shown over the years that there is a high chance of developing dementia later in life if you lose your muscle when you're younger, between 45 and 55 years old. So this is really important to maintain muscle as you continue aging and see the impact of menopause, low hormone in your system, has on muscle.
So once I have, let's say, do a biomarker and you do the urine test, what's the next step after that? First of all, like levels must have to drop, I imagine, or rise on some of these biomarkers. We'd love you to walk me through a little bit of those biomarkers.
Yeah.
Maybe some of the pathways that are relevant. I'm sure there's some researchers out here who probably study those biomarkers, perhaps. And then what do you do afterwards? What's the prognosis? If there is a treatment plan? With that information, what do people do with it?
Yeah, so one of my favorite biomarkers in the panel is called taurine. So taurine is a very common supplement. You can take taurine as a supplement. It is amino acid that it is important for muscle function. It's one of our major calcium regulator in the body, so it handles calcium while muscle needs to contract, but also is a powerful antioxidant that not many people know. And as we age, we lose taurine over time, and we need to maintain the levels of taurine optimal. If not, then start affecting muscle. Athletes will have usually a very huge turnaround of taurine all the time because they are metabolizing quite fast for activities. So we have a specific test that looks into athletes' life. But for the overall population, when we see low levels of taurine, we can do two things. One, we would like for you to implement a nutrition plan that's rich in taurine levels. So there is specific foods that are rich in taurine. So we first implement a nutrition plan with more taurine. If the taurine loss is super high, then we recommend a supplementation right away. So it's 1 to 3 grams per day of taurine as a supplementation. And that improves quite a bit performance over time. And taurine also affects glutamate, which is another one of our biomarkers. So glutamate is a neurotransmitter, but also is a very important amino acid for muscle growth and nitrogen availability in the cell. So when glutamate levels rise, it can increase your brain excitatory power. So you have all this sense of all the time be wired, and you can sleep well, affects your quality of sleep, your focus, your ability to do your daily tasks, and makes you really tired all the time. So glutamate levels impact quite a bit your life quality. And you may not have ever realized, because today also there is a glutamate test that you can take. And with a simple supplementation with taurine, you can actually lower your glutamate level. And we have shown that multiple times with our clients that will complain of multiple injuries all the time, the physiotherapist couldn't understand this person was all the time healthy, and they suddenly became really injured all the time, tired, couldn't sleep very well, did the muscle test, and we saw the profile of very low taurine, very high glutamate. We suggested the implementation. The physiotherapist started supplementing with taurine. 2 weeks, 3 weeks after, she came back to the office and they requested a second test. We did the second test. Her taurine levels increased, the glutamate decreased, and then within a month she was feeling so much better. No more injuries reported. Went to do a race, did really well in her race, and is now having such a much better quality of life. And the physiotherapist thought she had like a neuromuscular disease because then nothing else was explainable for her in her case, and was pretty much unbalance of amino acids that was really easy to treat. But if she didn't know that information, probably would have to go through many other testings and money wasted in the healthcare system and never diagnosed probably.
That's amazing. So talk to me a little bit about Myomar here. How have you been received by the broader healthcare ecosystem? What are some of the successes you've experienced, as a founder and CEO of a company which inspires a lot of people who want to do the same? And then what are some of the challenges you've also experienced in navigating a new novel diagnostic platform and all of that? So walk me through that a little bit.
Yeah, so when we started the company, we're pretty much rooted in science, and we want to have a very science-strong foundation. We didn't want to be just, this may work, and we're going to see it. No, we actually did a lot of clinical studies, and we continue doing clinical studies. We have a clinical study right now in GLP-1, so looking into muscle loss through GLP-1 at York University. Another one in menopause as well, and it just continues growing. But because our technology was pretty much based in science, there was a lot of money that has to be raised. We had to talk to a lot of investors, and the talk was always like this: "This is the idea. We're gonna have to show you that this is gonna work." And they voted for us and invested, and we were able to complete all these clinical studies. And we put the test in the market just a year or so ago. And we raised very little money compared to U.S. companies at our stage that raised $20 million before putting a technology in the market. We raised probably $3 to $4 million, and we have the technology in the market right now. It's across Canada, and we just opened a lab in the U.S. as well. So we're going to start implementing technology in the U.S. too and selling in the U.S. We actually we now had a partner in Japan. So we have a new investor, a Japanese investor called Suntory. It is a whiskey, very known whiskey company, but they also have a supplement line, which is interesting. It's the first one in the market in Japan. It's $1 billion enterprise, but they are really interested in longevity, wellness, aging well, as the Japanese population becomes really old. So they invested in Myomar. Now we are trying to implement in Japan as well. And Singapore also, we have some new partners. Yeah, so the company now starts to expanding, but it was really hard to get to this point. And with the support of our ecosystem so far, just Canadians have had access to our tests. We have 20 partners across Canada, clinics from Vancouver to Newfoundland. And we are shipping across the country pretty much on a daily basis, and people are testing. And I interview a lot of those people that come and test with us. I really like to talk to the end user, see the experience, and talk about the science, and explain to them why they should care about muscle, and just explain how this is important for longevity and quality of life as we age.
Amazing. So as we end this conversation, if you could tell me what your wish list would be for the next 1, 3, 5 years for both the public and their understanding of what you're doing, but also growing your company and scaling. Where would you like to see yourself, the company, and the general public and their understanding of sarcopenia and so on?
Yeah, that's an excellent question. So this morning we saw one of the talks that showed that when we prevent diseases, we can actually save millions of dollars through the government and improve people's quality of life instead of treating a disease, right? We're not a sickness health system. We should be a health system. So that also it is one of our major goals and one of the meaning of the company to give access to a test that is very accessible, by the way, so then people can treat or implement some things that are simple, but will improve so much your quality of life and decrease the chances of developing a lot of diseases that can be preventable. So this is one of the major things. We would love to have our tests implemented by the healthcare system and made this accessible and cheaper for everybody to have access to, especially women in menopause that are going through so many hormone declines. So we think it's very necessary. So we had someone of the healthcare system speaking just in the last panel, so we'd love to talk to her about these options. But yeah, like having the test more accessible and be able to implement a sarcopenia prevention program would be excellent.
Well, that sounds like a very exciting technology, really important. I definitely want to get tested for sure. I know a lot of people I know would want to get tested. So congratulations on doing this, and thank you for doing this. Everyone, please thank Dr. Andrade.
Thank you. Thank you very much.
Thank you. Thank you very much. Oh, of course, yeah. The next person who I'm going to be inviting up here is Lisa Hoffart. She is a physical therapist. She's got 2 degrees in kinesiology and in physical therapy from the University of Saskatchewan. Yep. She's worked with, and a master's, and she's worked with professional athletes, Olympians, people on the national team. So thank you very much. Please welcome Lisa.
Thank you very much.
Of course. So tell me about this relationship between sports. You're very passionate about it. You're the lacrosse team, the Roughnecks. Is it the Calgary Roughnecks?
Yeah, so I started, I was a physical therapist and I was the first female trainer in professional lacrosse. And first one that the Roughnecks had here. I took my babies on the road. I could tape a whole team of guys with a baby and a baby Bjorn. Yep, only hit them in the head a couple of times. It happened, it was true. And I work in private practice, so mostly musculoskeletal and orthopedics, and was lucky to, I studied at the University of Saskatchewan. I came here. Calgary has always been a hotbed for physical therapy training, and the rigor that we put each other through and the challenges that we but we like it. And Alberta has also been on the forefront where physical therapists can do special training, so I can order imaging relating to musculoskeletal injuries, and just kept going from there. Eventually studied translational health science at Oxford. So.
That's right, I want to get to that. So you went to Oxford, did your master's, and you're
Yep.
focused on translation and studying healthcare ecosystems.
Yeah, so translation's a sort of nebulous, sort of like physical therapy is, where you sit kind of in between a whole bunch of specialists and you learn how to talk to everybody. And translation is sort of like that too, where it's everything from the social science of why did that GP practice uptake something to, how does innovation even get started, and being very nebulous. I chose to do my thesis on looking at evaluation for the purpose of strengthening of the Calgary healthcare innovation ecosystem, because I'm not from here, I didn't study here, and I felt very adjacent to the innovation ecosystem. I didn't have a startup, and so I was just kind of there, yet I'm interested and willing to participate. So I was like, well, you should learn more about it.
So how does one break into something like that? How does one translate?
The ecosystem?
Yes.
So what I chose to do was I found a framework from the MIT Design Lab, and it is an ecosystem strengthening framework that was designed for resource poor areas, which no one's going to ever accuse healthcare of being over-resourced, and looked at a few other frameworks that weren't maybe as compatible. Also, I wanted to change the narrative. The most common framework is a triple helix, which is business, government, and academia. And then sometimes they're like, ooh, right, we need people, so we'll throw that in there. What's interesting about the MIT framework is that it has a central purpose. in the middle, which is how you get the strengthening to go along. And when I was doing my research, I discovered we don't have a purpose in our innovation ecosystem, like not a central one that we always tap back to. Are we looking at just research dollars? Are we just looking at data? Whatever. So for the purpose of my thesis, I threw patients in there because that was really, really missing. Really missing.
You know, speaking to Dr. Andrade about preventing muscle loss and so on, and you're really passionate about preventing injury, and you work with elite athletes.
Yes.
What are some of the takeaways from working with elite athletes that sort of the regular folk can take away?
Regular athletes learn about, they get exposed to a lot of testing all the time. We're testing them year round and learning about what their normal is, and then using that information to determine, do they need more rest breaks? Is this a good time to add that extra testing to really ramp things up? How do we get them ready for a major games or multiple events? So people can use their own data to start to learn about their own patterns and how things are affecting them, and knowing that each person's slightly different. And then using that information, maybe not, and learning how to interpret it. I think that's a good place to start.
Mm-hmm. So you work with Group 23.
Yes.
Tell me about Group 23.
So Group 23 is a multidisciplinary clinic, but in the sense that we really actually work together with each other. For example, we had 2 different EMRs because one served physical therapy better, but the problem was it didn't serve the doctors and their billing system. So in order to facilitate conversations and notes about each other about the patients, we changed to an EMR that we can share. We walk down the hallway sometimes and just to ask someone a question and say, am I missing something? Group 23 is also interesting. We have the head physician for the Flames works there, the head physician for the Stampeders works there, and a number of our doctors work with some of our national teams as well. Sometimes they travel, sometimes they don't. Actually, 2 of our doctors are married and both went to the Olympics. They were the doctors that were with the men's and women's hockey team. So I get to work with them. Those are my friends. And what's neat about Group 23, though, too, and from an innovation perspective, is that we do sometimes use things off-label with permission and with proper ethics and all the good stuff. And then we share what's happening. There's also a narrative that clinicians are really risk adverse and we don't like to adopt or we don't like to innovate. I got news for you. We do things that hasn't been published just because it works. I've been in private practice. If I don't succeed, I don't pay rent. That's how it works. So Group 23 has been really at the forefront, though, of we're trying to collect our outcomes and hopefully influence best practice down the road.
So tell me about that influence and best practice, because the summit is about precision health, about longevity, talking about how to make wider impact on our communities. So what's your wish list here?
My wish list is that we could, this is big. Where did all our politicians go? This is when I really need them. Because you had asked me before about even youth. I'm like, what if your health education started in high school? What if you learned biology and chemistry as part of food science? What if you learned physics, my dear passion, as biomechanics? Why is this exercise harder than that exercise? And engage them and stop treating young people like they can't learn or they'll do it when they want to or they don't take in information that way. They do. You'll be better, you'll be faster, you'll be higher, you'll be more ripped, and integrate that. And I think then the same thing from people come in and say, I'm not an elite athlete. And I'm like, you have a body and a heart and lungs and you want to be active and go to the mountains, and that's not different. So my wish would be that we can encourage everyone to be physically literate, health literate, and then able to handle their social media literacy as well.
That's amazing. I mean, we have an incredible assembly of like physicians, scientists, and had some politicians here as well to collaborate with. So what is some of the drawbacks or challenges you're experiencing in doing what you're doing? And how would you propose we get together more, we communicate more? Obviously, summits like this are very effective, but what is some of that?
Yeah, when I looked at the ecosystem, one of the challenges is, and I had to stick to just medical devices because otherwise now it's a PhD. So I would encourage people to be more not curious, nosy. Like go in and actually, maybe that's not your science forte, but maybe learn a little more about it. Go in and ask, ask the lawyers why they do what they do. Ask the clinicians why I care about what the lawyers do, how that impacts my business. I think the number one would be more nosy. And I think I have one more, though. I think I have, instead of talking about, I did have cheat sheets, just in case. It's okay to cheer about what we did 40 years ago, but you know what? We did it 40 years ago. I wasn't here, so I don't have any emotional attachment to it, so I can kind of poke that bear a little. And stop complaining. I am from a village of 400 people. Just figure out what we need to do to get better, and let's just do it, people. Let's do it. Our horizon for manufacturing's over there. Bring it here. Do it here. Stop, and let's go.
That's amazing. Very inspiring. Everyone, please thank Lisa Hoffart. Great to have you here.
Good to be here.
Yes, I love your energy. Every time I talk to you, you make me want to do things. And it turns out that's what your job is, to get people to do things.
It's all the free coffee, even though we're not supposed to be talking about that, right?
Talk to me about incentives. What's this whole gamification of incentives?
Yeah, so I'm not the founder of Optimity, but I've known the company since they started. And the CEO, who unfortunately couldn't be here, Jane Wong, is a really inspirational person. And her thesis is that we can talk a lot about the science of determining what people need to do to improve their health and the methodologies and policies to implement them. But a really important factor in making all this happen is actually motivation. And you'll hear health practitioners talk all the time about, look, there's tons of things I can say to patients, but they just have to do them. And I'm speaking on her behalf, which I won't do too much of because she can do it much better than me. But she comes from a mortality science background and worked in pharma for many years. And the thing she realized after an experience she had personally was that is a really important factor that not enough people talk about. So Optimity is a very simple platform that just drives incentives. Can we give you guidance, encouragement, a community, and prizes for making healthy decisions in your life? That's really all it does. But the magical thing is that over 80% of the people who've tried out the app, and there's 7 million people on the app today, have found something that keeps them coming back to it. And we've had increased engagement from organizations that have used the product over 40%. And so this is a really, really simple thing. It might sound like an obvious thing, but it's really hard to implement correctly. And we used a lot of behavioral science to do this. So what's exciting to me is we've been talking for the past 2 days all about all the different things we can do in the most technically esoteric and elegant manner from the perspective of genomics and AI, et cetera, to implement new things for people. There's also a way to get people to adopt them. And so this is just improves the opportunity for everybody.
Amazing. Talk to me a little bit about this behavioral science, because that seems to be like the black box magic trick. How do I get someone to do something? A physician's like, hey, go lose some weight before I put you on statins. Guy comes back, he's a bit heavier. And so how does one, what is the behavioral science here? Can you give us a little bit of insight, or is it proprietary, or what is it?
Really, it's just a model we've been tuning over the past 11 years that the company's actually been running. It started out in the space of employee lifestyle and behavior. So could we get people who are sitting at a desk all day to get up and stretch and that kind of thing? And then we realized we got such amazing results of it. We expanded it beyond that. But every time we added another user to the platform, we saw what worked and what didn't work, just with their own feedback. People are willing to give us their data of what they're doing because they actually get incentivized to do it. If you're not familiar with the product, first of all, it's free to download. Anybody can use it. And you get it's like a game. You get gems that you can then use to purchase products and opportunities in the platform. But the really cool thing is that our marketplace of products and opportunities are all health products. We actually have a virtuous cycle of making people feel even healthier, and then they get even more gems because now they have guidance on how to do that. Like, for example, through an Ultra Human Ring, which is the prize that we're giving away here. So that's really all it is we've just found out what works, what kind of content we should deliver to people, when we should deliver it, what is the power of social connectedness. So the pillars that we use, which I'm sure will be familiar to many people here, are physical health, nutritional health, mental health, emotional health, and financial well-being. All of the social determinants that drive a healthy society.
That's cool. So this feels like you're building some sort of economy here, like sort of like an intact economy, and you have this gem currency. Talk to me a little about this currency, because you hear about a lot of like incentive models, even like blockchain models where people are trying to do things like that. Is that something that you guys have explored a little bit, or how do you guys think about that space?
Well, the thing that we've discovered that's so magical about this is that it's really, really motivating. And I have a very simple piece of evidence on this, which is I've been sitting out there for the past couple of days, and I've had more than one person come back and go, "Who's winning? Can I?" And of course, the running joke has been, the problem is this conference is all in one room and it's snowing like crazy outside. So people are like, how am I going to go for a run? Maybe I'll just go for a walk up and down the hotel lobby. People are really motivated by this stuff because it's nice to compete on something so positive. So one of the next things that we're exploring at Optimity is how do we take this incentive model even out of the Optimity app and put it in other things people are trying to do to drive engagement on healthy behaviors. Because what we're interested in is we got 7 million people on the platform right now. We're interested in 100 million people who are pursuing their own health with their own motivation. Our app is one way to do that. There may be other ways to do that as well. And partnering with anybody that's got a community, maybe a nonprofit organization, maybe a contest, maybe attendees at a conference, maybe a health application themselves, can we introduce that incentive model in there?
So we live in what people call the attention economy. How have you cracked that attention economy to get people engaged? Like what's the trick there?
Yeah, we're leveraging it. So we have everything inside the product from what we call micro content, which is just simple things like, hey, a reminder on why nutrition matters. Here, let's give you a bit of instruction on how to do your stretching. Here's an exercise regimen, even down to like short little games, because actually the idea of taking a break out of your day and then doing something for yourself, calming your mind, playing a little Sudoku, that kind of thing, all of that matters. So all of these things are actually part of the product. And in one way, you could sort of say we're contributing to the attention economy, which has a lot of negative connotations, by having a product that drives user engagement. But in order to win the gems, you actually have to get up and move around. So that's the place we started from right from the beginning, was people were being too sedentary. And maybe you could argue they're being too sedentary because of the digital economy. Like most technologies, and as was said, I've been working in technology for a really long time. I actually work with a bunch of different companies, all in different corners of the healthcare realm, all using technology to make healthcare better. Technology is just a tool, and it can be used for positive things. It can be used for a lot of negative things. Sometimes we have to make sure we legislate how it's used. We're trying to take very common things that have been introduced in consumer mobile applications and apply them towards healthy living.
You mentioned legislation. What do you think about that in that space? It's quite unregulated, and then there's a push and pull. People don't want it regulated. The free market dynamic should take over. Some people think there should be oversight. What's your take on that?
Yeah, I find policy fascinating, and maybe I can't say this because the politicians all left the room. But I wouldn't claim to be an expert on it. But I think it is an important conversation we need to have. I am a technologist. I'm also the dad of 2 teenage girls. And like that's the center of the whole conversation around the dangers of technology, right? It's kind of interesting. Actually, I have sort of the opposite problem of a lot of people. My kids get mad at me because they say, "Dad, you're using AI too much. It's bad for the world." I don't know. Maybe they're trying to make me feel guilty, so I'll like Instagram for them. But, And I'm glad they asked me these questions because we have to think about this stuff. I had a conversation about this kind of thing yesterday, and something that I kind of lean on is we can move the world to a better place by reinforcing the positive. So outside of healthcare, my other kind of hat that I wear is I come from a product management background. I ran a product team. I taught product management. I teach in university. Thank you. So people who are product fans have all heard the story of something called the product market fit score, which was created by a guy named Rahul, who created the email app Superhuman. And one of the things he talks about is he figured out that the best way to make a business successful is by doubling down on people who are already being successful and figure out how to grow that, as opposed to just putting all of your effort into people who are not engaged and trying to make them more engaged. Now, why am I talking about that if I work for an engagement company? Because it's this idea of positive reinforcement. And I think if we can underscore, like we've done the past 2 days, and thank you everybody who's presented your stories here, because it's been super inspirational, of the positive things we can do with technology, I have, call me naive if you like to, I have a hope that that will downplay the negative use, right? Like, I mean, there's a danger in everything, but we got to have a little bit of faith in humanity here. And can we use AI instead of causing dangerous situations to reduce the care gaps? Can we make care more equitable? Can we reduce the burden on our overworked healthcare workers, deliver care to places that we don't have it? This is a big belief I have, and I think we got a long way to go that's full of possibilities. So.
You mentioned success. You must measure some outcomes from people who. What do those outcomes look like? And there's a lot of practitioners here, physicians. What are some of the success stories you find in the metrics?
Yeah, I mean, Optimity is an engagement platform at the end of the day. So we're not really measuring sort of biological science health outcomes because there's lots of ways to do that. We're actually measuring, like, does the person themselves feel like they achieved something? So we measure very simple things like, did they come back to the app? Did they achieve more challenges? Every challenge is a challenge to be healthier. And that's literally what we call them in the app, is challenges. And what we've actually found, the reason we've been operating for 11 years, we have 7 million people on the platform, over 100 partners, over 1,000 pieces of content. We operate in several continents, is because people keep coming back. So this idea that over 80% of the people have found engagement, 60% have found something about their health that they want to work on more. This is all self-reported data. Like, we're not mining this. People are just telling us this stuff by the way they're using the application. And it's amazing how we talk about us all. I come from a privacy background, just to kind of say it. I ran a healthcare data privacy company for 10 years. But it's amazing how people are willing to give their information if you can help them make better decisions towards a more positive life. And so these are the things we're tracking. For organizations that we partner with, we're seeing an increase by over 40% in engagement of their members if we add this thing to the other experience that they already have.
So as a technologist, you see all these changes in like hardware, software, services. Where do you see us going? There's an alignment here. Are there misalignments you're concerned about? What would you like to see the tech sector kind of help you out here?
I mean, I get tired at the end of the day because of all of the conversation that I'm in and that I see online and stuff like this. It's funny because we're living this interesting dichotomy, and I feel like one of the previous speakers just talked about this. On one hand, you've got the AI scientists and the technologies we have in the world. One of my other companies that I work with has some of the world's leading healthcare AI data scientists on the team. It's pretty amazing. And there's this narrative that like apps are all going to go away, and foundational LLM models will be able to create anything for us and do anything for us and help us make all these decisions. And yes, there will be a disruption to the workforce, but yes, more jobs will be created. I love that statement that was made earlier today. But on the other hand, yes, healthcare in Canada still uses fax machines and pagers, right? So it's not just a conversation about invention. It's a conversation about motivation, and it's a conversation about helping people with adoption. Healthcare is not lacking technology possibility. And as somebody who mentors digital health entrepreneurs all the time, I work with like 9 different accelerators and incubators. Every single day I meet yet another engineer, I'm an engineer too, all my love to them, who go, you know what? Healthcare must not have realized that AI exists. I'm going to add it and it's going to solve all the problems. And I'm like, there's a graveyard of digital health startups that tried to make admin and primary care work better. It's not just about the technology. It's about understanding the buying process. It's understanding how decisions get made. It's understanding how people are incentivized and motivated. And I mean providers, I mean policymakers, I mean patients, I mean families, and all the motivations between them. So all of this is solvable. Again, it actually comes from a product management framework. But I'm excited by all the things that are happening. I have this kind of thesis. I say, well, everything could be a healthcare company because everything impacts our health. And the business case for digital health is really, really simple. This was in the first slide of the pitch deck to investors I did for my company 11 years ago, the company before Optimity. The modern healthcare industry was created to be transactional. It's not its fault. That was said earlier today too. I love that. It was not anybody's fault. It was created to be transactional because when it was created, the majority of the things we did in healthcare were helping soldiers who were shot in a war. Now, 97% of the cost of healthcare is chronic conditions, which are 3 factors. Long-term relationship with the patient, a lot of people involved in care, and a heck of a lot of data. And the system isn't built to support that. So every single thing we do in technology, whether it's AI, cloud, Web3, IoT, I remember when mobile was a thing. I worked for BlackBerry for 8 years at the beginning of that company. All of these things have an impact to the way that healthcare can operate, but it's not going to be successful unless we think about the adoption process, the procurement process, the training process, and the onboarding process. How do we do that? Celebrate every single win that we have.
That sounds amazing. Feels like a victory to sit here and talk to you and talk to everybody here and be a part of this summit. Please help me thank Balaji.
Thanks very much.